In 2019, India was projected at the second position, reporting 77 million Indians aged between 20 and 79 years with type 2 diabetes. And lo and behold, it is anticipated to rise to 101 millions in 2030. India has a specific phenotype called, quote, Asian Indian phenotype, unquote, that differs from other ethnic groups characterized by higher percentage of body fat, higher waist to hip ratio, representing central obesity, very rapid decline in the beta cell function, high insulin resistance, with higher risk of cardiovascular complications and neuropathic diabetic complications. Diabetes and its complications, if not well managed, can lead to frequent hospitalization and premature death. Persistent hyperglycemia can lead to acute and chronic diabetes complications. Diabetes management is challenging owing to a higher burden of both microvascular and macrovascular complications, attributing to high morbidity and very high mortality. At diagnosis, about 10 to 18%, almost 20% diabetics present with nerve damage at the diagnosis of the disease. About 50% of diabetics, half of them, develop peripheral, what we call distal sensory motor symmetric polyneuropathy, causing foot infection, fractures and amputation. In fact, to make a long story short, diabetic neuropathic foot is one of the most important cause of lower limb amputation in our country, next to the road accidents. And it's the same that we have to amputate neuropathic foot. Amputating an ischemic foot is perfectly maybe acceptable, but not amputating a neuropathic foot where it's totally preventable. 1/3 of the patients develop peripheral diabetic neuropathy with neuropathic pain and symptoms such as paresthesias, formications, and allodynia. Allodynia meaning severe pain, leading to impaired quality of life. Goal of neuropathic pain management includes, most important, is the strict glycemic control and preventing recurrence of the condition that can cause neuropathic pain. One of our objectives and important goal is to alleviate neuropathic pain, improve the physical and the psychological functions, thus improving the quality of life. I cannot overemphasize that the strict glycemic control over long term, for a long period, is the mainstay of diabetic neuropathic management. No doubt about it. Strict glycemic control. However, let us remember that it does not reduce or does not halt the progression of the diabetic neuropathy. We know today that metformin is recommended as the #1 drug, most effective drug in all the guidelines, the most effective first-line drug in type 2 diabetes. But its use has been linked to vitamin B12 deficiency, which increases the risk of peripheral nerve damage. The American Diabetic Association and the AAC, the American College of Clinical Endocrinology, both their guidelines recommend evaluation of vitamin B12 deficiency in patients who take metformin. And mind you, that metformin taken as the first line of drug. As studies conducted in recent years have linked metformin use to diabetic neuropathy. Therefore, it is very important that we must measure the vitamin B12 level in the blood. Now, today there is a demand for new therapies to be used alone or in combination with current diabetes management for diabetic neuropathy. And one such proposed therapy is vitamin B12. And this vitamin B12 supplementation is very important, as more than 50% of the diabetic patients report vitamin B12 deficiency. And this deficiency may accelerate the progression of diabetic neuropathy. In diabetic patients or in persons with diabetes, vitamin B12 deficiency is associated not only peripheral neuropathy but with multiple neurological problems like subacute combined degeneration, neurodegenerative manifestation, autonomic neuropathy, and also sometimes delirium, dementia, and even at times axonal demyelination. Therefore, vitamin B12 supplementation is of paramount importance. The British Society of Hematology guidelines recommend that vitamin B12 levels must be checked in clinical suspicion of deficiency, such as peripheral neuropathy. And peripheral neuropathy per se is irreversible. And it is like a point of no return when it manifests fully. But it may be too late at that time to treat it once symptoms develop. Whereas vitamin B12 is a neurotropic agent that has affinity for neuronal tissue. It is vital for maintaining and regenerating the peripheral nerves. It promotes myelination, promotes nerve regeneration, and decreases the ectopic nerve firing. And this ectopic nerve firing is responsible for the electric-like pain, the tingling, the numbness. People say current passing through the leg. I know that is most important. So it prevents that ectopic nerve firing. Oral vitamin B12 supplementation for 24 weeks for 6 months in adults with diabetic patients with polyneuropathy has showed decreased frequency of very important symptoms. I quote one study where this vitamin B12 supplementation produced 48%, take it as 50% of lowering of the tingling in the diabetic foot, 43% weakness disappeared, and in 38% pain reduced significantly. Therefore, symptoms like tingling, upper limb symptoms of tingling, numbness, pain, ataxia, impaired position sense, impaired vibration sense, pinprick sensation, pin and needle sensation, and knee reflex and the ankle reflex improved after the supplementation of the vitamin B12. Dear friends, therefore today the B12 therapy has emerged as one of the most significant, most contemporary management of diabetic peripheral neuropathy, both at the level of prevention and management. It also did improve in the ulnar nerve in the hand. It improved the conduction velocity. It improved the amplitude and also improved the distal latency. Now, the recommendations on the management of diabetic neuropathy related to vitamin B12 deficiency. Dear friends, if the levels are below 145 nanogram per liter, and we must seek advice to measure IFAB. IFAB stands for intrinsic factor antibody testing, but mind you, it is not available in many of the centers. Therefore, if somebody has symptoms and levels below 145, the management is very important. And if IFAB is not available, which is the case many parts of the country, initiate treatment with intramuscular hydroxycobalamin, 1 milligram every second day until symptoms improve and symptoms totally disappear. And following that, please remember, one has to maintain intramuscular hydroxycobalamin 1000 microgram every 2 to 3 months for life. Once the level is above 180 nanogram per liter, if there are no symptoms, no further investigation or no further injection necessary. So I would like to emphasize that if the level of the vitamin B12 less than 145, it's very difficult to get the intrinsic factor antibody test done. Management can be started, initiating treatment with intramuscular hydroxycobalamin 1 milligram every second day. I'm re-emphasizing until the symptom disappear, and then we maintain intramuscular hydroxycobalamin about 1000 microgram every 2 to 3 months for life. Once the level attain 180 nanogram per liter and there are no symptoms, no further treatment or no further investigation necessary. Therefore, dear friends, today vitamin B12 has stood out as one of the most effective management. Dear friends, diabetic neuropathy is a multifactorial problem. And the commonest complication, I would call it the commonest complication, most important contemporary complication causing lot of morbidity, mortality, diminution in the quality of life. Just imagine a patient having tingling, numbness, pain, electric current passing through the leg. It interferes the sleep, interferes the working activity of the particular person with diabetes mellitus. In these patients, vitamin B12 plays an important role in the regeneration of the myelin sheaths and nerve function. Thus, it adds to the armamentarium of the current diabetic management, and it is worth it and will change the destiny of the patient, change the attitude of the patients, and provide relief. A little of it will go a long way in alleviating the neuropathy symptoms, preventing it, and postponing it.